But let's see what happens.
So I'll start. So again, thanks, welcome everyone. This is our 70th, I believe, episode of Mrftt HIV STI Echo. I'm Dr. Boyce. Thanks again to Dr. Edwards for being here, Dr. Peters for joining us for the first time. Hi, Cyrus. I'm really happy you're here because the topic today, I think, when I was thinking about it, one of the things I remember was having a conversation with you about the screening you get. So I'm going to actually be poking you a little bit, but it's okay.
Yes, I made sure that I'm here for this session today.
All right. So let me share my screen. All right. Give me a second. Okay. I'm hoping everyone can see clearly. Yeah. All right. So, anal neoplasia and HIV. So, it's a broader topic than I originally anticipated because there's a lot to it, and a lot of it is changing because at the recently conducted CROI research conference, which is a conference on retroviruses and opportunistic infections, some recent data came out that kind of spurred my interest to kind of go over this in some fine detail. Because it is an important issue. We have cases, and Dr. Edwards himself, diagnosed a couple of cases of, anal disease very recently, last couple of years, that would have otherwise gone undiagnosed had the patients not noticed something was wrong. So the question, I think, for all of us as providers is, what do we need to do to make sure that we are doing the screening to make sure that it's not up to patients to come to us saying, I have an issue before we interview. So just want to acknowledge all the great support we get from ITEC and from the University of New Mexico in the construction of this program, and as well as what is now CTEC, who is our bigger brother in Jamaica. So we have a conflict of interest, and we're going to talk about some of the epidemiology and risk factors for anal neoplasia. Apologies for the siren. We're going to describe some of the screening and diagnostic protocols to detect anal neoplasia, discuss the treatment options for anal neoplasia and anal cancer, and to outline the impact of HPV vaccination on the risk for anal neoplasia. So when we say the term, what we mean is, abnormal cells lining the anus, which is a very layman's way of putting it, and exists in a spectrum anywhere from atypical squamous cells of undetermined significance or ascus to anal cancer, and it shares a lot of pathologic and epidemiologic similarities, as well as the way we speak and describe it and the management with cervical cancer. So just to discuss the anatomy and the similarities in the anatomy between the rectum and the anus, the cervix and the anus. So the cervix, as most of us would know, there's a transformation zone, what they call a squamo-columnar junction, where the lining of the vagina is a certain type of lining called squamous epithelium, which is designed for high traffic areas like trauma, that sort of thing. It's lines of skin and areas that are exposed to a lot of trauma and exposed perhaps to the surroundings. Changes to columnar type epithelium, which is the line you get in, for example, in your intestine and the lining of the womb itself, which is, and so there's a certain point both in the cervix and in the anus itself where that squamous epithelium changes to columnar epithelium, and it happens at a point called squamo-columnar junction. The reason why that is important in both cervical disease and anal disease is that there's a high turnover of cells, as well as a high vulnerability of cells that are rapidly dividing to insults that can become premalignant and malignant and then progress to cancer. So as you see in the anus, it's at this line called the dentate line, and the cervix, depending on age, it may be greater or lesser exposed. The older someone gets, especially the postmenopausal, the transition zone tends to go further up into the cervix itself and is shielded from external irritants. So we're going to just have a conversation about what we mean when we talk about anal epithelial neoplasia and high-grade and low-grade squamous intraepithelial lesion. So anal epithelial neoplasia essentially means what it says, that there is neoplasia or abnormal cells or precancerous cells in the lining of the anus itself. And it is staged based on how much of that lining is involved with these abnormal cells. So if the lower third is involved, that's AIN1. If the lower 2/3 is involved, that's AIN2. And if all the entire thickness of the anal lining is involved, that's AIN3, or something considered either carcinoma in situ or microinvasive cancer. And AIN1 is considered, this is actually not quite right, it's supposed to be low-grade squamous epithelial lesion, so condyloma or AIN1, and high-grade squamous intraepithelial lesion, HSIL, is AIN2 or 3. These high-grade lesions have a greater risk of progression to cancer over time. So what are the risk factors for anal neoplasia? So HIV infection is one of the major causes. The other one being HPV, I will come to that, which is it is essentially the major cause, HPV that is. But in terms of HIV infection, I'll show some charts later on, there is a 19 times higher risk of anal cancer in persons with HIV versus HIV negative cohorts. And they found that a lower CD4 count, either at the time of diagnosis or at any point in time previously, what we call CD4 nadir. So for example, someone who came to us in 2005 with a CD4 count of 2, and in 2022, the CD4 count is 800, has a higher risk of anal cancer because of that low CD4 count, how many ever years ago, than someone who came to us in 2007 with 17, let's say, a lower CD4 count of 400, and it's now 800. Right? Even though CD4 counts are similar, because that other person at lower CD4 count is a higher risk of cancer in the future. HPV, as we said, it's one of those 90-90 rules again. So 90% of anal squamous cell carcinoma, which is the most common type of anal cancer, is related to HPV infection, and primarily 16 and 18. Again, 90% of the HPV-related cause of squamous cell carcinoma is HPV, and again, primarily HPV 16, which is about 70-80% or more, and in some studies, of all the causes of HPV-related anal disease. And there was an interplay between HPV and HIV. So persons with HIV who acquire anal HPV have a greater risk of acquiring a high risk subtype, so 16 and 18. They have lower rates of spontaneous clearance because when someone is exposed to HPV, the natural history is such that they can sometimes clear the virus completely and then it's gone. But in persons with HIV, the rate of clearance of virus is less, and there's a faster progression from mild disease to severe disease and to cancer. There's a greater risk of developing multiple lesions. There's a greater risk of developing recurrence. So HIV makes HPV disease worse in all different types of modalities. Smoking is a recognized risk factor as well. It's well documented, and it can even negatively affect remission rates post-treatment, right? Chronic immunosuppressive state, separate and apart from HIV itself. So in one of the studies, I think they looked at lupus, another one looked at a solid organ transplant recipients. So they are on long-term immunosuppressive treatment. They have a higher risk of developing anal cancer. Unprotected receptive anal sex, and there's a little asterisk here, but we'll come to it later. And that obviously would be related to the risk of acquiring HPV directly into the anus via sex. Men who have sex with men have a much higher risk of developing anal cancer, and in some studies up to 80 times higher in men who have sex with men who are living with HIV versus men who have sex with men who are HIV negative. And we'll demonstrate that in a little bit. And again, high number of sexual partners, again, similar to cervical cancer, again, greater risk of acquiring HIV and HPV. And there was an increasing incidence in ART era, and we're talking about the early ART era, primarily because people were living long enough to develop the cancer. There wasn't anything specifically due to at the time with the cancer per se. It's not declining, and that may have something to do with vaccination, may have something to do with early initiation of antiretroviral therapy, with sort of teasing out some of the reasons. It is important to note, however, that women who develop high risk, who have acquired high risk HPV subtypes, so cervical or vaginal or vulval cancer, even related to HPV, have a higher risk of having developed high risk anal HPV, even if they have no history of anal sex. So one of the things we have to be mindful about is any person, as a matter of fact, even male or female, who has genital HPV, whether it's penile, cervical, vaginal, vulval, has a high risk of anal HPV as well, even in the absence of anal sex. And that should inform how we screen. So one of the things we should be doing potentially, and the data is hopefully will start bearing this out, in persons who have CIN 1, 2, and 3, for example, in the chart above there, the higher the degree of cervical dysplasia, which CIN 1, 2, and 3, that's cervical intraepithelial neoplasia, the higher the grade means the worse it is, the greater is the risk of anal HPV. So if the person has no cervical dysplasia, there's a 6.2 baseline rate that goes as high as 48.5 in CIN 3, and then about 1/3 of person with in situ cancer, and more than half of person with invasive microinvasive cervical C have evidence of anal HPV, even if there was no previous history of anal sex documented. So this is a chart that was done in a study called the Anchor study that I'll refer to later on, that essentially demonstrates the incidence rates of different types of cancers in men and women living with not living with HIV. Some are living with HIV, some are just in general population. And it is the general thinking that anal cancer is not common, it's rare, but based on some of this data, it's not as rare as we think. So for example, if we look at the second bar, this is men of sex with men who are living with HIV. The incidence rate of anal cancer is 131 per 100,000, which is higher than prostate cancer, higher than lung cancer, right? Let's see, what else? Kidney, thyroid, higher than lymphoma. So it's colorectal cancer. So these things are not rare. We screen for these things, right? And it's comparable to prostate cancer and higher than a lot of the others. And in HIV negative men who are living with HIV, it's still comparable to colorectal cancer, a little less than lung cancer. And compared to in persons who are HIV negative with the rate of anal cancer, it's what, 60-something times, almost 70-something times. It's really quite high, right? So essentially what this chart should tell us is that we need to consider anal cancer as a significant risk factor and start screening for it in the same kind of way as we think of prostate cancer as a serious risk issue, when we think of colorectal cancer and lung cancer as a serious risk issue, and start screening for that. So this was just a graphical representation of what we spoke about earlier with the rates of anal cancer rising over time from the early ART era, stabilizing and then dropping. This is about 2012 here. This is 1996. And the yellow dashed line is anal cancer rates over time. So there's been a gradual but very small increase, and it's otherwise relatively rare, right, among persons who are HIV negative, but very much more common among persons living with HIV. And this is just, I think, maybe the final chart I have, just demonstrating how much higher the risk of anal cancer is among persons both with symptomatic HIV, which means persons who are unwell and not virally suppressed, as well as persons who are well adherent or unsuppressed. So oddly enough, in persons who have asymptomatic HIV, the anal cancer rates are higher than in persons who have symptomatic disease. And that might have more to do with prolonged survival and developing disease in someone who has long survival of HIV. And this, the x-axis is not linear, it's logarithmic. So this is 1, this is 2, this is 20, this is 100. So you're talking about 40-something times higher than standard in persons who are asymptomatic, and almost 70-something times in persons who have asymptomatic disease. So in terms of types of cancer that affect the anus, this is the WHO classification from 2000. We spoke already about anal intraepithelial neoplasia, the types of epithelial tumors that can happen. Squamous cell carcinoma, again, most common. There's adenocarcinoma, which is about less than 20%, and the other types of cancer that are rare, right? There are non-epithelial tumors, which are generally benign, carcinoid tumors, melanomas, and secondary tumors. So tumors can metastasize to the anus and rectum from other parts of the body. So just to let persons know, I try to keep the graphic slides to a minimum, no blood, no gore, but just to let you know, some of these slides might be a little, some people might find a little bit unpleasant. So how does anal neoplasia / cancer manifest? So first thing to know, it may have or commonly has no symptoms, at least, especially in early disease, right? And some of the changes can be very subtle. So changes in pigmentation, change in consistency of a certain part of the perianal skin, or sometimes under just rectal examination, the lining of the anus itself. Sometimes you can see a visible or palpable lesion. So in the case of the cases that the others would have diagnosed, the patient came and said, "Is this thing my anus? And I'm not sure what it is." And one of the things we have to be very careful about as physicians is just dismissing it and saying, "Oh, you have a little something back there that bleeds every now and again, it's probably a hemorrhoid," right? And miss the cancer. Right? Or we think, well, it might be HPV or something else, and just dismiss it as a hemorrhoid or water and miss the early cancer. Other symptoms that might manifest would be things like itching, bleeding, which can be spontaneous, but is most commonly post-coital or post-defecation, and in severe disease can actually lead to anemia. Pain, which is, again, in more advanced disease, when the cancers are still invade surrounding tissue, it can cause persistent pain. Pain during coitus in the case of someone who's undergoing receptive anal sex. There can be a change in bowel habit, and that can be, I've seen that with constricting anal tumors, where essentially the stool comes out more pencil shaped and people suffer the intermittent obstruction. And in advanced disease, signs of distal or regional spread. So, the spread to the inguinal nose, which are the nose, maybe groin, or signs of distant metastatic disease. So these two were taken from a slide presentation. I'm sorry I didn't put the attribution, but these are two lesions. The lesion on the left was, the person's general practitioner told them, it's just a hemorrhoid. The lesion on the right told them it was a wart. Both turned out to be cancer. Right? So this is just to illustrate the fact that we need to be mindful and not dismissive anytime a patient comes with a lesion. Always inspect it. And if it's suspicious, either refer for biopsy if you have the capability to do biopsy right away. So let's talk about how we screen for anal neoplastic disease. So the goal of screening is obviously to detect and eradicate anal dysplasia early, right? To stop the progression to cancer, or if there is a cancer there, to detect it at an early point in time whereby the treatments that are available are more likely to be curative. So I'm going to talk about two screening methods that really have to be thought of as paired. So anal pap smear and cytology and high resolution endoscopy, because one without the other is useless, just in a certain sense. So if you have the ability to have resolution endoscopy, then go ahead and do the pap smear. If you don't, the pap smear doesn't help you, because if you detect some abnormal cells on the anal pap smear, what you're going to do about it? You can't do directed vision. You can't biopsy. You don't know what sort of lesion you're dealing with, so it may not be helpful to you at all, right? And we did mention that there was a lot of similarities between, cervical screening for cervical disease and screening for anal disease. So an anal pap smear is essentially the same sort of procedure that you would do for a cervical pap smear, where you would insert a Boyce sort of Dacron swab into the anus at the site of the squamous junction, and come out in a spiral pattern over about 10 seconds. It's very sensitive for anal disease. It's between 63 and 93%. The difference is that, especially in persons with HIV, is not as sensitive. No, sorry, specific. Sorry, I have it wrong. The sensitivity side, the specificity is low. So you would think that if you were to do a pap smear and you get a high squamous, highly abnormal squamous cells that you would think that would correlate with, high-grade disease. And if you got a, milder-looking squamous epithelial cells, that would correlate with less severe disease. But that is not the case with anal pap smears, and particularly not the case in persons who live with HIV who have anal pap smears, and that you can get a low-grade lesion on pap smear, and on endoscopy is a high-grade lesion or something worse. And you can get a high-grade squamous epithelial lesion on pap smear and a normal endoscopy. So given that discrepancy, some of the algorithm that for management of an abnormal anal pap smear is any significant, whether it's low grade or high grade, proceed to endoscopy and biopsy, because the pap smear is not going to help you reliably distinguish between high grade lesions. And remember, if you miss a high grade lesion in someone living with HIV, the progression to anal cancer is faster than in someone who's HIV negative. One of the other techniques that we can employ is also to sort of add some more information is to do PCR for HPV, so that we can detect whether or not the lesion is associated with high-grade HPV or low-grade HPV. It is not yet clear how to work that in to how we think about dealing with the lesions. For example, if someone has a low-grade lesion, HPV 16, or abnormal squamous cells of undetermined significance and HPV 16, so high-grade HPV, low-grade findings on cytology, what do we do? I'm not sure if there's any evidence to inform the decision, right? As opposed to, for example, in cervical disease, if you have high-grade HPV, you consider that as a significant risk factor for cervical disease, and you would act accordingly. So this is just a quick diagram of what you would see on a anal pap smear, which is not that different from what you would see on a cervical pap. Remember, you would put the cells in a liquid medium and would stain them. The cells on the left are normal, where you see the dense nuclear material and a lot of cytoplasm around it, because the squamous cells typically have very small nuclei, pyknotic nuclei. In the slide to the right, you see the nucleus are a lot larger. There's much less cytoplasm. These are not normal squamous cells. So this would be considered to be abnormal anal pap smear. So high resolution endoscopy, which is essentially colposcopy on the anus, right? And it's the same sort of techniques you would use. You would insert your endoscope. You would insert a swab with 3 to 5% acetic acid or low-dose iodine. Abnormal lesions, you get this Acetal White phenomenon with the acetic acid, and it's reversed with the iodine. Abnormal cells do not pick up the iodine, and that can add to how you would assess your colposcopy findings. And of course, you would biopsy abnormal areas, and if there are multiple abnormal areas, you biopsy multiple times, because you might have AN1 in one area, but AN3 in another area. Right. So this is a picture of what the normal squamocolumnar junction looks like in the anus. Right. So you actually see that horizon that's arrowed. Right. So the squamous epithelium is this way, the columnar epithelium is further in. And this is what we call the Acetal White phenomenon that all of us will be familiar with pap smear. So after you instill your acetic acid, the abnormal areas tend to get this white look to it, so you would biopsy this. So it can be anywhere from a squamous metaplasia, meaning the cells starting to turn abnormal, to intraepithelial neoplasia or even cancer, right? And this is a series of 4 different endoscopic findings. The top left A is normal. The top right, you see that sort of stippling pattern, which are actually blood vessels that you see, and that's an abnormal phenomenon, as well as you notice that Acetal White stain and maybe a little bit of bleeding here, some friability, right? So this was actually a high-grade dysplasia on biopsy. Lower left, that's area C. You can again see some sort of vascular patterns, that kind of almost like tree-like appearance. And this was a carcinoma in situ. You see again, a marked acetal white phenomena as well as some bleeding. And D, the areas of ulceration, right? And this also was positive for high-grade dysplasia. So the question is who to screen. And for a long time, there wasn't a lot of good data and evidence to back this up. But in terms of the persons who are at highest risk, so we know men of sex men live with HIV, right? Especially if there's a previous history of HPV disease anywhere else. Women living with HIV, when we had the conversation that women living with HIV are at greater risk of acquiring HPV as a result of the HIV status, particularly women who have any previous history of HPV disease. Persons with low CD4 counts, either current or nadir. Any symptom of anorectal disease, so if a patient comes regardless of age, a young MSM, and said they will have some discomfort, some pain, some bleeding, regardless of previous history, of previous anal disease, previous HPV disease, they need to be screened. HPV negative men of sex with men, remember they still have a higher risk of anal cancer, but there is still a question mark around that in terms of what the data shows. As we mentioned before, HPV negative women with high risk HPV, as we showed in the chart earlier, there is the rate of high risk HPV and cervical intraepithelial neoplasia go up. So is the rate of having acquired anal HPV. And chronic immunosuppression. So again, this is one of the areas where you might consider screening, especially the other risk factors that would push us in that direction. So in the absence of anal pap smears and high-resolution endoscopy, one of the really valuable tools that we can have is simple digital anorectal examination, DRE or DARE, right? And in many cases, that will pick up the lesion because, as I mentioned before, with some of the lesions, even in early disease, there's a consistency change in the mucosa. It doesn't feel the same. It can feel gritty. You can feel a lump or a bump, or almost as though there's like a rough area when you pass a finger over it, and that can clue you into the fact that there is a lesion there that needs further attention. And you could probably just a simple endoscopy under direct vision and biopsy the area or refill, depending on what resources are available. You can detect the size, number, and shape of lesions. You can detect the friability of bleeding, so if there's blood in the finger, for example. And one should consider doing digital rectal examination other than screening for prostate disease on an annual basis as part of the examination for high-risk groups where, as I said, anal pap smears and HRAs are not available. So in terms of biopsy, of diagnosis, the diagnosis must be made on biopsy because sometimes the difference on clinical examination, even on endoscopy, between a low-grade lesion and a high-grade lesion can be very difficult or impossible to tell, right? And as I said before, even benign lesions can sometimes have areas of high-grade disease or even microinvasive cancer within. So it might be well worthwhile to submit all of those samples for biopsy, especially if you have a recurrent lesion. It may be well worthwhile to submit it for biopsy to ensure that missing a pre-malignant or malignant disease. So in terms of staging, the TNM classification, tumor, nose, metastasis, and I'm not going to go through that entire thing. But it would require, if a cancer is diagnosed, C2 MRI of the chest, abdomen, and pelvis. One can also do, in addition to clinical palpation of the inguinal nodes to detect nodal spread, an endorectal examination can also detect some of the deeper nodes in the inguinal chain that might change the way you stage the disease. And typically, the greater the stage, the worse the prognosis. And in terms of management, so with precancerous lesions, that's LSIL or AN 1, 2, and 3. Ablative treatment reduces the risk of progression to cancer, and this was actually not always known with certainty, which was one of the reasons why, in terms of how we follow up persons who have abnormal anal findings, there was not yet, until fairly recently, known for sure that intervening was better than observing with premalignant disease, because in some cases, high-grade squamous intraepithelial lesions could just regress or disappear, right? So the question was, are we making a difference in terms of progression of disease by intervening and getting rid of these lesions? And we'll come to that very briefly, but in a nutshell, the anchor study did in fact show that. So in terms of what one can do, one can apply topical agents like 5-fluorouracil, electrocortical or hyphication, infrared coagulation, imiquimod, which a lot of us know as Aldara. Trichloroacetic acid can also be used in some cases, and they're generally well tolerated. And this is the anchor trial that I referred to. Essentially, it was a randomized controlled trial in which many of these men were randomized who were diagnosed with a high-grade squamous epithelial lesion. Were randomized to either observation or to intervention, where they would have applied those treatment techniques that would have outlined previously to remove the lesions. And what was found over about 25 or 26 weeks of follow-up and subsequent was that there was a 7% reduction in the risk of progression to anal cancer in persons with high-grade squamous intraepithelial lesions who underwent intervention with whatever modality, doesn't matter which one it was. And some of them may have had multiple treatments. There was a significant reduction in progression to anal cancer than in observation. So that recent finding changed a lot of guidelines in terms of what to do about the one, screening, right, and two, intervention if an abnormality is found. So this is an algorithm in a 2017 paper about what you do, and then this of course assumes availability of anal pap smears and high-resolution endoscopy, and it is essentially recommending that, especially in persons with HIV, because of the low specificity of anal pap smears in telling the difference between let's say AN1, AN3, that any squamous lesion should proceed to HRA and biopsy. And in terms of treatment, so with low-grade lesions, you can consider treating or monitor. With high-grade lesions or cancer, you definitely must treat. And if pap smear is normal, you would repeat the anal pap smear or where it's not available, digital rectal examination every year. And in persons who live with HIV and in persons who are HIV negative, every 2 to 3 years. So what do you do about anal cancer? So squamous cell cancer of the anus tend to respond relatively well to treatment. Sometimes radiation alone is sufficient. The Negro protocol actually recommends combined chemotherapy and radiation with an 80% remission rate after 5 years. It does require regular follow-up post-treatment with rectal examination, endoscopy, monitoring for nodal recurrence every year for 5 years, and annual follow-up with CT of the chest, abdomen, and pelvis to look for evidence of distal metastasis for the first 3 years post-treatment. If there's persistent or recurrent disease despite treatment, the surgical approach is recommended with abdominopelvic resection, in which case you remove the anus, the rectum, the perineum, and the pulmonary colostomy put in place. And if there's a lesion that is localized and non-invasive, actually, you can just do a wide local excision and cure, and that can be curative. So in terms of prognosis, in the early ART era, the 5-year survival was less than half, was 41%. And in more recent times, it can be north of 70% 5-year survival rate in persons living with HIV. Survival is negatively correlated with CD4 nadir, as well with unsuppressed viremia. So in persons who are diagnosed, it's important, if not yet, to get them on treatment, suppress their virus, get their CD4 counts back up, so that you give the best chance of long-term survival post-diagnosis. So in terms of prevention of anal neoplasia, HPV vaccination among men in persons who live with HIV, some of the data has been conflicting. It's well documented that HPV vaccination does reduce cervical disease in women. There is also evidence going back at between 2011 and 2014. Several studies were done mostly in HIV negative young men of sex with men, so 16 and 26 years old, and was shown to reduce the risk of anal intraepithelial neoplasia. It reduced persistence of anal HPV infection, and it also reduced recurrent external genital lesions and persistent HIV. There were at least 2 or 3 studies that showed that. There was another study, again, this is in 2014, that showed a decreased post-treatment recurrent rates of high-grade intraepithelial neoplasia. So this is someone who has anal neoplasia, received treatment, for the subsequent treatment was vaccinated against HPV, and there was demonstration of a lower rate of recurrence of those lesions. But there were some subsequent studies among men of sex with men, and some of them were older than that 26-year-old cat with some of these studies, that did not show as good a response, right? Especially in older men of sex with men. So there is still some questions about what the data show, especially in older persons. The recommendation in terms of vaccination with both, at least with the American guidelines, with both the quadrivalent, which was some of the HPV vaccine that would have been used in some of the earlier studies, and the nonavalent, which is the newer version, which is 9 strains of HPV, still recommend from 11 to 26. The decision to vaccinate after the age of 26, and we do vaccinate against the age, up to the age of 45 at MRF, and I think we should still continue doing so. As an individualized decision, we can have a conversation with the patient about it, but I think it should still be offered for whatever benefit it does offer. I think there was some evidence that it may not necessarily be cost effective, but given the risk of anal cancer later in life, it may well be something that I think is defendable. And in terms of the other things that we can do to prevent anal neoplasia, anal cancer, so smoking cessation, as with many other different types of cancer, remember, smoking both increases the chances of developing anal cancer and increases the risk of treatment failure, lack of remission, post-treatment for anal neoplastic disease. Early initiation of antiretroviral therapy to keep the CD4 count as high as possible, as early as possible, given what we know about how immunosuppression affects progression of disease. Treatment of anal epithelial neoplastic disease, again, the ANCHOR study definitely demonstrated that there is benefit to it in terms of reduction of progression to anal cancer, reduction in number of partners, which would reduce the risk of coming in contact with HPV and HIV. There was a question around the efficacy of condom, because you remember sometimes the HPV lesions are not covered by the condom. So depending on, and there can be asymptomatic shedding as well. So there are a couple of studies that did not show much benefit from condom, but that still, I would still recommend the use of condom in persons who have HPV disease. So in summary, anal neoplasia and anal cancer are relatively common among men and women living with HIV. Screening of high-risk groups is both feasible and appropriate, and is feasible, and appropriate management is effective in reducing the risk of progression to anal cancer. The evidence for the effect of HPV vaccination on a risk for anal cancer in older persons living with HIV is conflicting, but in my opinion, we should still go ahead and offer it. And that's the presentation. Thank you very much. And I will just open the floor for any questions or comments. And thank you for your attention.
So Dr. Boyce, I don't know if this is too simple a question, but in layman's terms, how would ceasing smoking help against anal cancer?
So smoking and continued smoking. Remember, smoking is a risk factor for a lot of different cancers. Anal cancer is one of them, right? Reduction of the carcinogenic drive, shall we say, the ongoing carcinogenic drive, right? That smoking would cause would tend to continue the ongoing risk of developing cancer. So if you remove that drive, you reduce that continued additional risk of developing cancer. Right? Because remember, it's multiple things.
Great.
So it's smoking, it's partners, it's lots of different things. So as many things as you can remove in terms of driving that person towards that cancer destination, the better.
Okay, gotcha. Thank you for that.
Dr. Boyce. Hello.
Yes, I can hear you. Go ahead.
All right. So in January of 2018 in New York, I was diagnosed with high-grade squamous epithelial lesion. Yeah. And I was being followed up every year because the protocol there, MSMs, every year they undergo the anal pap smear and the HRA. Let us fast forward. Because of COVID and stuff like that, I was unable to go back to New York for any kind of follow-up. And I have since been bumped out of the system. Yes. So, I mean, we do not have the anal pap smear and the HRA here in Trinidad. And you did make suggestions as to the digital examinations and so forth. So my question is, with respect to follow-up, is this already being done?
So in terms of what, so I'm not aware of any site that does HRA in Trinidad on men. The techniques are transferable in the sense that it's a colposcope, right? It's the same thing they'll use on women, but I would suspect most, so you're not going to get a gynecologist to do it. The only person that might have that level of training might be a colorectal surgeon, right? To do the endoscopy, apply the acetic acid and the iodine and do biopsies and so on. But I don't know that's done in the public sector. And if there was someone doing it privately, I'm not aware of who they are. We can do digital rectal exams. We can do standard endoscopy, so without the benefit, unfortunately, of the colposcope, which is essentially a sort of a traveling microscope. And we will not be able to intervene to the extent that we would if we had that. In terms of what the follow-up for you would be, now, after you were diagnosed with HSIL 3 years ago, there wasn't another opportunity to follow up to see if it had regressed or not.
No, there was not.
So I think we may have to see you and do an exam to see if there's anything still there. I may have to do some looking up as to what the referral pathway would be in terms of further steps if there is still any evidence of something going on.
Mm-hmm. Okay.
a little trickier in Trinidad because I don't think we have good access or any access, to my knowledge. And even in the US, so for example, when they were doing the anchor study, where they were doing, pap smears and all that sort of thing, it's not widely available even in the States, right? There's certain academic centers and large treatment sites, usually primarily coastal, right? So east seaboard, western seaboard, and some across the southern parts of the southern United States. But it's not a widely available modality. So I think that does speak to the need, now that especially as the anchor study came out, I know that we know there is benefit to treating these lesions in terms of reducing progression over time. It might be something that we need to think about in a serious way, in terms of adding as another layer of the treatment we make available for men of sex with men. Dr. Peters? Oh, sorry, was that it?
Okay, one final question.
Yeah.
So based on your presentation, is it that MRF is already screening MSMs especially for HPV, anal HPV?
So not systematically. So for example, during men's clinic, and my patients who will allow me, I will do an rectal examination if there's a lesion, either biopsy it or refer, depending on what I find, right? But not on a systematic basis to say that it's part of the standard package of services we give when a MSM comes in for an annual checkup. And I think having gone through this, that the exercise of doing research for this presentation, I think we will need to start thinking how we can do a better job at that.
Okay, understood. Thank you.
Go ahead. I see you have your hand raised.
Hi, good afternoon. Very comprehensive presentations. It's not a topic I usually hear much about, so I'm glad for this opportunity this afternoon. Now, asking my question based on the MSMs and the reproductive and sexual health of men post-radiotherapy. Is there any sequela? Is there any sequela after radiotherapy? Anything that would interfere with their sexual or their reproductive health, especially for the MSMs?
Yeah, so thank you for that question, and that's a very relevant point. So even in our own experience, we have had some of our MSM clients who would have experienced, and there's still a patient who still has, radiation proctitis, radiation cystitis, potential for infertility if they are not careful about shielding the gonads from radiation. So there is that possibility of specifically, especially with radiation, of injuring anything in the path of those X-ray beams. So bladder, especially parts that can't move. So the bladder, the rectum, and parts of the reproductive system. I'm not familiar enough to see whether or not it would cause things like sexual dysfunction, impotence, infertility per se, but that is a possibility. And we have had some difficult cases with some of the older radiotherapy machines that were active in Trinidad.
Okay, thanks.
In terms of Cyrus, you said you fell out the system in the US. You can't get back in?
Well, yes, I can go back. I can go and re-enroll.
Yeah, I think that may be, these things could progress quite quickly, so I think it might be worthwhile for you to, go back and re-enroll in the program. if there's a problem, remember we have Dr. John up there, so he might be able, David John, he may be able to, reach out to somebody for you. But I still think you should go up and, let them investigate to make sure this thing didn't progress,
All right. Well, I actually was contemplating going up for summer,
Right.
But yes, I will look into it. Definitely.
I think it's a good idea. And I say if you need, I think I could contact Dr. John and see, if he can use some influence, to get you seen quickly,
Okay.
All right.
All right. Thanks a lot.
And in terms of anal cancers, I actually see, at least we actually see quite a few every year. I see probably 3 or 4 every year. And in terms of anogenital cancers, we've actually seen quite a few penile cancers also in men, a couple of vulval cancers in women. So it is an issue. How we diagnose penile cancers, they come really strange looking lesions. I do a biopsy and then, we recently had one probably about must be a month ago, and we had to send them to the urology clinic. Dr. Todd usually reaches out to them so they see the patients quickly. But again, the HPV and the anogenital cancers, especially in the HIV patients, we tend to see a lot now, at least compared to the HIV negative population. But I must say the couple of patients with the anal cancer, it does respond to the radiotherapy quite well. And I think I've seen about 3 patients who had radiotherapy a number of years ago, and they're actually still doing quite well. I recall one particular patient who had radiotherapy and he was over-radiated by a mistake, or I don't know what had happened, and he ended up with a huge mass in the anus there, and it's a mess to treat. So that's the only one who really had some complications. Most of them did quite well with the radiation.
And Dr. Boyce, as previously done, you'll be sharing this presentation with us for us to share in the WhatsApp group while we work on doing the video in time for persons to see as well.
All right. Okay, let's see. Okay, all right. So I said we're a small group today, but again, thanks everyone for coming on. And I think we'll probably wrap up around just a couple of minutes early. So we'll start a reminder to the rest of the WhatsApp group, but just to remember that next week, Friday, is a special session with Chris Behrens. He's his usual support of our ECHO program, which we very much appreciate. The topic is yet to be decided, but he always comes with something really interesting. He's on vacation right now. We wish him a nice long rest, because I know infectious disease specialists in the United States during COVID had it brutal. So, oh yes. So wish him the best. And we shall see you back again next week, Friday, for our 71st episode of Mrftt. Thank you so much. Take care and stay blessed.
Thanks, everyone.
Thank you.